Good morning, all of you. Today we shall discuss about 2-3 topics. One, there was a request for a discussion or a revision on autonomic nervous system. Plus, some of the students had sent a request for a revision on nerve muscle physiology. Those are very big topics. I will just briefly go through these topics and try to focus on some important aspects of it. And after we complete with the autonomic nervous system, I shall briefly discuss about some properties of muscle and then properties of the nerve. Now let us start with the autonomic nervous system. Now we know that the whole of the organization of the nervous system is something like that. We have got a central nervous system, peripheral nervous system, and an autonomic nervous system. Now in this, when we see the functioning of the body in terms of nervous system, there are motor nerves and there are sensory nerves which are controlling the actions of the motor skeletal muscles. The sensory neurons or the sensory system is concerned with the perception of the senses in the body, sensory system, where the perception of the various senses are taken care of, and then the autonomic nervous system. Today we are just discussing about the functioning of the autonomic nervous system. As the word says that this nervous system controls the autonomic functions of the body. So what is the autonomic functions of the body? The autonomic functions of the body are the control of the heart rate, the control of the blood pressure, the control of the respiration, the control of the GI functions, the control of the renal system. So all these functions are autonomic functions in the body which are not under our control, and there is a separate nervous system which is called as the autonomic nervous system. Now basically, if you see the autonomic nervous system, they are composed of two other parallel systems. One is the sympathetic nervous system and the other is the parasympathetic nervous system. Now the parasympathetic and the sympathetic system have got both two nerves, have got both two sets of neurons and one ganglion. So those neurons which are present before the ganglion are called as the preganglionic fibers, and those which are present from the or originate from the ganglion are called as the postganglionic fibers. So this autonomic nervous system functions as a motor system for most of the visceral organs, that is most of the visceral tissue in the body concerned, and these visceral organs are mostly present in the abdomen and in the chest wall. It is controlled with controlling the system for the supply of the diameter of the blood vessels and also for the glands. Now mostly the preganglionic axons of the autonomic nervous system are located in two places. Whether it is sympathetic or parasympathetic, the preganglionic fibers are located either within the cranium, within the brainstem, or they are present in the spinal cord. Fibers from these ganglions start and they move around to innervate the target organ, that is to innervate the visceral organs, or they innervate the blood vessels or the glands, and these are called as the postganglionic neurons. So the postganglionic neurons take their origins from the autonomic ganglion. They are unmyelinated, they run through the body and ultimately reach the glands or to the viscera in the body. Now let us see the sympathetic. The sympathetic ganglion are located very close to the spinal cord, whereas the parasympathetic ganglion are located close to the effector tissues. In other words, the sympathetic pathways have very short preganglionic fibers and a long postganglionic fibers, whereas the parasympathetic fibers have got a very long preganglionic fibers and a very short postganglionic fibers. Here if you can see this. See this is the sympathetic nervous system, where the sympathetic nervous system is also called as the thoracolumbar outflow, because the nerves which are controlling the sympathetic activities are taking origin from the thoracic segment of the thoracic segment and the lumbar segment of the spinal cord, and hence it is called as a thoracolumbar outflow. That is, they start from T1, T2, they can till L1, L2. So this is L5, L6. So this is the thoracolumbar outflow here. Now if you see this, the fibers which are in dotted lines or in black color, they are all the preganglionic sympathetic nerve fibers. They come out of the spinal cord, the thoracic segment and the lumbar segment, and these preganglionic fibers take their origins in that particular spinal segment. They come out of the spinal cord and then they end in a ganglion. This ganglion is known as a sympathetic ganglion. So after they end in the ganglion, there is another second set of neurons which takes origin, and these fibers which are originating from the ganglion here are called as the postganglionic fibers. So these postganglionic fibers, they travel here and they supply the different viscera. So there is a sympathetic chain where you will find that they are taking its origin near in the sympathetic chain and they are supplying to the postganglionic fibers. Whereas the parasympathetic fibers, when they takes its origin, they travel a long way and their ganglion or autonomic ganglion are present only very close to the target organ. So they have got a long preganglionic fibers and a very short postganglionic fibers. Now if you see this here, you will find that the whole of the autonomic nervous system, every organ is supplied by both sympathetic and parasympathetic, only their actions are different. Let us see the parasympathetic fibers here. So if you see the parasympathetic fibers, the parasympathetic division is also called as the craniosacral outflow. So the nerves which are coming out from the cranium and the nerve fibers which are coming out from the sacrum have parasympathetic function, and it is called as the parasympathetic neurons of the parasympathetic division. Hence it is also called as the craniosacral outflow. So now see, what are the nerve fibers, what are the cervical nerve, what are the cranial nerves which are having this? The third cranial nerve, the seventh cranial nerve, the ninth cranial nerve and the 10th cranial nerve. So 3, 7, 9 and 10 is the cranial part of the parasympathetic division, and the sacrum comes from S1 to S5. So this is the sacral part. So together this craniosacral outflow is the parasympathetic supply. Now where do they supply? If you see this diagram here, the third nerve is taking its origin and supplying to the eye. So the parasympathetic nerve to the eye comes from the third cranial nerve. Similarly, this is the parotid glands where it is coming. The glands which are present in the head, neck and the face are being supplied by the 7th and the 9th cranial nerve, that is the parotid gland and the submandibular gland. So here the parasympathetic division or the parasympathetic supply to the secretory salivary glands is from the 7th and the 9th cranial nerve. Whereas the 10th cranial nerve supplies parasympathetic fibers to the heart, it supplies to the lungs and the bronchi, and it supplies to the gastrointestinal tract till the cecum, and then also to the genitourinary tract, that is to the ureter. So the cranial division or the cranial part of the parasympathetic nerve is supplying to the eye through the third cranial nerve, to the glands, to the 7th and the 9th cranial nerve, especially in the head and the neck region. And the 10th cranial nerve, that is the vagus nerve, supplies to the heart, the lungs and the gastrointestinal tract. To the genitourinary tract, it supplies to the ureters. Whereas when you see the sacral part, the sacral portion of the parasympathetic division, it is supplying the parasympathetic fibers to the genital tract. It supplies to the urinary bladder. So the parasympathetic division, parasympathetic supply to the urinary bladder is from the sacral segment. Whereas to the ureters, it is coming from the vagus nerve. Whereas the lower colon, that is the descending colon and the transverse colon, is all supplied by the sacral nerves. When you go on to the other side, where you will find that the sympathetic division also is supplied by the thoracolumbar outflow. So here you will see the sympathetic nerves going into the eye, to the glands, to the heart, that is the sympathetic nerves to the heart, the sympathetic nerves to the blood vessels, to the smooth muscles also of the vascular system, then it is to the liver and the pancreas, and also it is to the sweat glands, bladder and the adrenal medulla. So this is from the sympathetic division from the thoracolumbar outflow. Now the next question is, what are the receptors present? Basically you should know that the parasympathetic nerve supply, the parasympathetic division secretes certain neurotransmitter, and these neurotransmitter acts on certain receptors, and these receptors are known as cholinergic receptors. Whereas the sympathetic division acts through the neurotransmitters by activating the adrenoreceptors, and there are two types of receptors, alpha adrenergic receptors and beta adrenergic receptors, which we shall see in the subsequent slides. So here it is the sympathetic supply which is coming here. You can see that it enters the sympathetic chain, enters in the sympathetic chain and then comes out and exists to supply the organ there. Now, when you see the physiological anatomy of the parasympathetic nerve, as I have just discussed here, the oculomotor nerve supplies fibers to the sphincter pupillae and the ciliary muscles. The seventh cranial nerve, that is the facial nerve, supplies to the nasal glands, the lacrimal glands, and the submandibular glands. The ninth cranial nerve supplies parasympathetic nerve fibers to the parotid gland. The vagus nerve gives motor supply or innervates the parasympathetic division to the various visceral organs. The sacral segment of the parasympathetic division gives fibers to the descending colon, the rectum, the bladder, and to the genitalia. So here the same fiber, same diagram is given here. See the third cranial nerve through the ciliary ganglion going to the ciliary muscles of the eye. Here we have got the seventh cranial nerve going through the lacrimal glands and to the nasal glands and to the sphenopalatine ganglion. The ninth cranial nerve supplying again to the various nerve submandibular gland, and the 10th cranial nerve supplying to the heart, the stomach, the pylorus, the ascending colon, and the transverse colon, whereas the sacral segment supply to the descending colon and to the bladder muscles. So this is the sacral innervation, this is the cranial innervation to the whole of the body, and ultimately they are controlling the autonomic nerve supply. Now here it is the action. If we discuss this in the action wise, you remember one thing. Parasympathetic supply to the heart, that is to the vagus nerve, will slow the conduction impulse. It will decrease the heart rate. So what is the action of the parasympathetic nerve to the heart? The parasympathetic nerve to the heart is supplied by vagus. In other words, what is the action of the vagus on the heart? It decreases the heart rate and it slows the conduction rate. Then what is the action on the bronchi? Whereas what is the action on the stomach? What is the action on the glands? Remember one thing, on the GIT and on the glands, the secretions of the parasympathetic stimulation effect is all the secretions are increased. Wherever there is a gland, if you want to remember it this way. Parasympathetic stimulation to the glands will cause increased amount or copious amount of secretions. What will happen to the contractions? The contractions will increase. So this is the way it will happen. There is a increased secretion, there is a increased smooth muscle contraction, then there is a relaxation of the sphincter which is happening. Let us take the bladder, let us take the urinary bladder, or let it be the gallbladder, let it be the glandular secretions, let it be the pancreatic secretions, or let it be the secretions of the glands in the stomach or in the large intestine. Basically, this is the general golden principle. First, all the secretions are increased. So parasympathetic stimulation or vagal stimulation to the heart, you will find that it is increased. The gastric secretions are increased, the intestinal secretions are increased, the parasympathetic secretions are increased, the salivary secretions are increased. Let it be the submandibular gland or the parotid gland or the bladder, you will find that there is a contraction of the bladder. So this is about the secretion. What about the smooth muscle? We know that all these glands and the GI tract is supplied by smooth muscles. So what will happen? The contractions will increase. So it increases the contractions. Then there are sphincters also present. You have got sphincters, the upper esophageal sphincter, the lower esophageal sphincter. We have got the gallbladder sphincter of OD. Then you have got the sphincter at the bladders. So all the sphincters will be relaxed under the influence of parasympathetic stimulation. So this is the general rule which you remember. Exactly opposite will be to the sympathetic activity. So what happens in sympathetic activity? Whenever there is a sympathetic stimulation, the secretions will be reduced. There will be decreased contraction and the sphincters will be contracted. That is why when there is a strong sympathetic stimulation or when you are very angry or tensed up, you will feel that there is dryness of the mouth. Why there is a dryness of the mouth? Because the salivary secretions are reduced. Normally there is a continuous secretion happening in the saliva. Continuously small quantities of saliva is being secreted. Under the sympathetic stimulation, when you are tensed up or when you are angry or under emotional outbursts, the dryness is because the sympathetic stimulation is causing very less amount of salivary secretion. So that makes your oral cavity dry. So remember this, secretions are reduced, sphincters are relaxed, contractions are decreased. Now this is the same thing here. In organ wise I have given sympathetic stimulation to the eye, pupillary dilatation, parasympathetic pupillary constriction. Glands, as I said, that they increase the secretions GI tract increase the smooth muscle activity, increases secretions. Whereas in the heart, sympathetic increases the heart rate and the force of contractions, whereas the parasympathetic decreases the heart rate. Now let us come on to the neurotransmitters which are being released. Now we know that the sympathetic nerves release a neurotransmitter which is called as norepinephrine, hence these are called as adrenergic nerves. Parasympathetic nerves release acetylcholine at their nerve endings and they are called as cholinergic nerves. All the postganglionic, almost all the postganglionic sympathetic nerves will release norepinephrine. So remember, the neurotransmitter in the all postganglionic sympathetic nerve is norepinephrine. All postganglionic parasympathetic nerves will release acetylcholine. All preganglionic sympathetic nerves will release acetylcholine. All preganglionic parasympathetic nerves will release acetylcholine. So remember one thing, a preganglionic sympathetic nerve or a preganglionic parasympathetic nerve will release acetylcholine. A postganglionic parasympathetic nerve will release acetylcholine. A postganglionic sympathetic nerve will release norepinephrine except for the sweat glands and the blood vessels. Remember this. Now this is all in biochemistry, where how is norepinephrine synthesized? Tyrosine gives rise to dopa to dopamine breaks down to norepinephrine and epinephrine. Similarly the acetylcholine. So now what is the requirement? Here you will find that for a neurotransmitter to act, there are certain requirements which should be fulfilled before the neurotransmitters is released at the synaptic junctions. First, there should be a synthesis of neurotransmitter. There should be second, synthesis of synaptic vesicles. Third, there should be the storage of the neurotransmitters or entry of the neurotransmitters into the synaptic vesicles. There has to be a release of the neurotransmitter. Once the neurotransmitters are released, next the neurotransmitters in the synaptic cleft have to bind to the neurotransmitters on a receptors. Then there will be a generation of new action potential. Once this action is over, the body has to see to it that the new neurotransmitters has been reuptaking happens, so that there is no loss of these neurotransmitters. Now briefly let us see about the receptors. There are two receptors, norepinephrine or the adrenergic receptors are of two types, alpha receptors and beta receptors. Alpha receptors are located on the blood vessels and they cause vasoconstrictions. Beta receptors are further divided into beta 1 and beta 2. Even then there are alpha 1 and alpha 2. But for this sake at your level, just remember alpha and beta receptors, still little more depth, alpha 1, alpha 2, beta 1, beta 2 receptors. In pharmacology, later on when you go, you will read in detail. The parasympathetic nerves release acetylcholine. Acetylcholine, again there are two receptors, it excites two receptors, or there are two receptors on which the parasympathetic neurotransmitter acts. One is the nicotinic receptors and the other is the muscarinic receptors. Where are the nicotinic receptors found? The nicotinic receptors are always found in synapses. Which synapses? Between the pre and the postganglionic neurons. Which neurons? Both sympathetic and parasympathetic neurons. So in other words, the receptor which is present at the preganglionic, at the synapse of the preganglionic and the postganglionic sympathetic neurons, and the receptors which are found in the preganglionic and the postganglionic parasympathetic neurons are all nicotinic receptors. Where are the muscarinic receptors found? Muscarinic receptors are found on the effector cells, on all postganglionic parasympathetic fibers. That means the vagus nerve innervating the heart. So on the heart you will find that the muscarinic receptors are present. So this is the way it goes off at all the junctions where the parasympathetic nerve fibers end on the viscus or on the glands, you will find that it is a muscarinic receptor. So here the same thing which I told you in the initial few slides. This is the sympathetic nervous system, the preganglionic fibers taking its origin from the spinal cord, the preganglionic sympathetic fibers coming out, ending in the sympathetic ganglion, the postganglionic fibers taking its origin and going to supply to the target organ. It may be the GIT or it may be the sweat gland or it may be the bladder. So a small preganglionic fiber, a long postganglionic fiber, sympathetic fiber. Whereas in parasympathetic fiber, as I said, it is the cranial and the cranial or the sacral outflow. You will find that the fibers takes origin from the either cranial division or from the sacral division. They travel a long distance and reach the target organ. Near the target organ, they end in a ganglion. From there, you will find that the postganglionic neurons takes its origin. So you will have a long preganglionic fibers and a very short postganglionic fibers, because the ganglion is present very close to the target organ. Now, what about the receptors here? See here, this is the ganglion, or this is the ganglion where there is a synapse between preganglionic and postganglionic sympathetic fibers. It is nicotinic receptors. Here also there is a synapse between there is a ganglion here between the preganglionic and the postganglionic fibers, and this is a parasympathetic ganglion. So the parasympathetic ganglion receptors are also nicotinic receptors. To put it the other way, the receptors in the sympathetic ganglion or in the parasympathetic ganglion are nicotinic receptors. Whereas the receptors which are present at the target organ, here you see this is the postganglionic neuron, postganglionic parasympathetic neuron ending on the target organ. Let it be the GI tract, the smooth muscle of the stomach, intestine, heart or the lungs. Here the receptors will be the muscarinic receptors. Whereas this is the postganglionic fibers, sympathetic fibers ending same on the target tissue, let it be the heart or the GI tract or the stomach or the bronchial glands. Here the receptors will be the adrenergic receptors. So postganglionic parasympathetic fibers at the target organs are having adrenergic receptors. The postganglionic parasympathetic fibers at the target organ will act on the muscarinic receptors. This is all which I have been telling you in a long class. Every day I have told you earlier. Presynaptic membrane, postsynaptic membrane, this is the synaptic cleft, this is the synaptic vesicle. The synaptic vesicle is with a neurotransmitter, and into this the neurotransmitter gets secreted. Same thing, presynaptic membrane, this is the postsynaptic membrane, synaptic cleft, this is the terminal here. Here calcium is present, calcium has to diffuse inside. Once calcium diffuses inside, it binds with the neurotransmitter, that is the synaptic vesicle. The synaptic vesicles will move from their storage area toward the synaptic cleft, and there they will release the neurotransmitter. This will cause the opening up of the channels, acetylcholine binding onto this receptor. The gate was closed, binding will cause opening up of the gate. Bypass all this because this is already easy and given in your books and it has been discussed earlier. So there is one last thing which I wanted to tell here is that there is a tone which is called as a sympathetic tone and a parasympathetic tone. That means that every division of the autonomic nervous system, that is either let it be the sympathetic division or the parasympathetic division, it is exerting certain influence or causing certain amount of basal secretions of the neurotransmitter. This background activity which is happening in the absence of any active stimulus, or the background activity which is happening during resting condition, is known as the tone, and for sympathetic it is sympathetic tone and parasympathetic it is parasympathetic tone. So normally sympathetic tone normally causes about 50% of the vasoconstriction. That means we know that the smooth muscle, we know that the vascular walls or the arterioles are always in a constricted mode. Slightly they are having a vascular tone. So this vascular tone is because of the sympathetic tone which keeps it in a partly vasoconstricted region. So 50% of the vasoconstriction is because of the sympathetic tone. Increase the sympathetic tone, there will be intense vasoconstriction. Decrease the sympathetic tone, the arteriolar diameter will increase, and you will find that because of the reduction in the tone, the size of the arterioles will increase. So increasing the sympathetic tone can cause severe vasoconstriction. Decreasing the sympathetic tone may cause vasodilatation. It is not only for the arteries, it is for the big arteries and the small arteries, and also for the veins. Similarly, a small amount of parasympathetic stimulation always is there, and that provides the background GI activity. Now we will end with the autonomic nervous system. Then there was also a request for the nerve muscle physiology. I will just briefly go through that nerve muscle physiology here. Okay, let us see about this excitation contraction coupling mechanism. As the word suggests, it is excitation followed by contraction. Okay, excitation, contraction, coupling in a skeletal muscle we will see. Briefly, if time permits, we will discuss about the differences between the skeletal muscle and the cardiac muscle EC coupling. Some slides will go through it. First, what is the mechanism of excitation, contraction, coupling? What does excitation, contraction, coupling means? Excitation, contraction, coupling means in a muscle fiber, first of all, an electrical activity takes place which causes the skeletal muscle to get excited to prepare for its contraction, to prepare for its subsequent activity. Once the excitation part is completed, then the actual mechanical part takes place, and that is contraction. So this is called as excitation, contraction and coupling mechanism. So what do you need it? So for a contraction, excitation, contraction, coupling to take place, there has to be a triad. We need a transverse tubule and there has to be a longitudinal tubule. There is a receptor on this tubule that is known as the dihydropyridine receptors, and on the longitudinal tubule there is a RYR channel that is known as the ryanodine receptor channel. So basically the requirement for excitation, contraction, coupling mechanism, anatomy, that is the physiologic anatomy, is there has to be a triad. In that triad there has to be a T tubule, there has to be a L tubule. The T tubule receptor is called as the DHP receptor, which is dihydroxypyridine receptor. The longitudinal tubule is the ryanodine receptor channel. Now, what is the mechanism of this excitation? First, there is a arrival of the action potential. Then, once the action potential is reaching into the muscle mass, that is into the sarcoplasm there, into the muscle fiber, there is a release of calcium in the sarcoplasm. Once the calcium is released in the sarcoplasm, it binds, the binding up of the calcium to troponin C takes place. When this binding takes place, there is an exposure, there is a configurational change which is happening, a mechanical change which is happening. Once the calcium binds to the troponin C, binding of this calcium to troponin C will uncover the active site. Once the uncovering of the active site takes place, the actin myosin cross bridges takes place and the shortening of the muscle takes place. After this shortening has taken place, in a few seconds, the calcium will move away from it. Then will move away from the troponin. The troponin C will cover the active sites on the cross bridges, and then the relaxation will take place. So this is the basic thing I have explained to you. We'll briefly go through the slides. Now here, excitation part, you will see that it's a neuromuscular transmission. You know that the nerves are innervating the skeletal muscle. Let's say the fingers of the biceps, the biceps muscle. The biceps is supplied by motor nerve coming out from the brachial plexus. So the brachial plexus nerves are arising and those are ending on the muscle fibers of the biceps muscles. So if the biceps muscle has to contract, then this has to receive an impulse from the nerves, and ultimately the impulse has to end on the biceps muscle for it to contract. So first there has to be an electrical phenomena. This electrical phenomena has to pass through the neuromuscular junction, and this part is the excitation part and is an electrical event. Then once the electrical event is finished, what is happening? Calcium is being released into the sarcoplasm by the T-tubular system. Once this calcium is released, then the mechanical part takes place, and that mechanical phenomena is skeletal muscle contraction. So here this is the neuromuscular junction, where the NMJ junction you call, this is the synapse, this is the nerve muscle, this is nerve fiber, this is the muscle fiber, the nerve fiber ending on the muscle fiber, these are the it is the cleft which is present, this is the subneural cleft, and this is the neuromuscular junction. Same thing is being shown here. See this is the transverse tubules. All these are the transverse tubules. This is the, you will find that the cytoplasm is there. These are the small myofibrils are present. This is the mitochondria. Here you will find that the dark fibers and the light fibers are present. To see more in detail, here you will find this. This is the transverse tubule. It is all the transverse tubule. This is the plasma membrane. These are each is the myofibril. Myofibril is having the actin myosin filaments. This is the sarcoplasm and the segments of the sarcoplasmic reticulum. So here you will find that from calcium has to come from this release from this sarcoplasmic reticulum, enter into tubule where the T triad ends. Here it opens into the exterior. So what is the transverse tubule system? It is nothing but the invagination of the sarcoplasm. This T-tubule is mostly located at the junction of the A and the I band on either side of the sarcomere, and this T-tubule helps in conduction of the impulses to the inside of the muscle fibers. Now, what are the L tubules? The L tubules of the sarcoplasmic reticulum, they are nothing but they are derived from the endoplasmic reticulum. About 10% of the skeletal muscle fibers constitutes of the L tubules. It is the storage house of the calcium, and within the sarcoplasmic reticulum, it is the calciquistrin which binds to the calcium. This calciquistrin can, per molecule of calciquistrin, can bind about 40 calcium molecules. This L tubules at the sarcoplasmic reticulum is not in continuation with the extracellular space. So here it is the T tubules. T tubules is nothing but the invagination of the sarcolemma. It is filled with extracellular fluid. It penetrates the muscle fibers and branches deep into it and helps in the transmission of action potential. So this is the function of T tubules. Then what does the L tubules do? It is the terminal cisternae and the longitudinal tubules. They bind to the T tubules and they form the storage of calcium ions. The receptors, as I said earlier, the T tubule has a DHP receptor, whereas the SR has got a rhinodine receptor. So here you can see the diagram, the junction between the two terminals, cisternae and the T tubules are present here. This is the T tubule, this is the terminal cisternae, two cisternae are present. Here you will find that there is this is the terminal cisternae, and here you will find that it is the dihydropyridine receptor. So action potential comes here as it goes inside the muscle fiber. It spreads laterally into the sides. When it goes into the sides, it releases the calcium. Once the calcium is released into the sarcoplasmic reticulum, contraction will take place. This is the triad, very beautifully explained here. You see, this is the AI band. This band is known as the AI band. Here is the AI band, this is the Z line. The gap between the two Z lines is known as the sarcomere or the Z disc. This is the one sarcomere. In every one sarcomere, you will find that there is a triad. Now, what does this triad see? What does this triad constitute? See this triad on here. This is the transverse tubule. So, it is traveling across the myofibril. So, this is the T tubule. Here, this is the sarcoplasmic reticulum binding on both sides of it. It constitutes the triad here in a skeletal muscle. So the same diagram is being explained here. You will find that the steps are being given here 1, 2, 3, 4. This is the triad. Here you will find that action potential is entering into the T tubule. Here you will find that and going into the surrounding sarcoplasmic reticulum. I will explain to it on the other slide. Here it is. This is the muscle action potential which has come from there, from the nerve, passed through the neuromuscular junction, reaching onto the muscle, and here it goes inside to the muscle fiber. This is the muscle fiber, this is the inside the sarcoplasma. So once the action potential is transmitting down, here you will find that there is the sarcolemma here. Here on either side they are abutting the T tubule. So the impulse binds here and reaches into the transverse tubule. From the transverse tubules it goes here into the sarcoplasmic reticulum. The impulse goes here, calcium is stored here, the calcium is released. Once the calcium is released out, this calcium now comes out of this sarcoplasmic reticulum and then it binds on to the troponin C. The troponin C binding will cause the troponin C to move away from it. This complex troponin C calcium complex will move away and expose the active sites on the tropomyosin. Once the active sites are removed from here, then you will find that the cross bridges will form, the actin myosin channel will take place. Once the actin myosin channel is activated, the cross bridges will move, then there will be tilting will happen. As a result of this tilting, the two of them will come together and contraction will take place. Once the contraction has taken place, you will find that the calcium is taken back. The calcium is taken up from this back and stored into the sarcoplasmic reticulum. Calcium removal from the troponin myosin will now cause the uncovering of the active sites, and they again will break up, the cross bridges will go break up and relaxation will take place and they will go back to their own site. So this is how exactly the excitation contraction coupling takes place. So here it is again given in a diagrammatic manner here. Here you will find that there is an action potential moving inside. As it moves inside, the impulse goes inside. When the impulse goes inside, it releases the calcium ions here. They are coming out from this calciquistrin, going into the sarcoplasmic reticulum, and they are causing contractions. Once the contraction is over, this calcium pump is an active pump, will pump calcium from there in the sarcoplasm back to the sarcoplasmic reticulum, and they will be stored here. Just to follow it, I will repeat it again. See this again. Action potential coming down from the T tubule, entering into the L tubule, stimulating the ryanodine receptors, calcium coming out, going into the sarcoplasmic reticulum, causing the contraction here. Once the contraction is over, then they are released, the calcium site releases out, and through the calcium pump is pumped back into the sarcoplasmic reticulum. So this is how the action potential takes place. And the excitation contraction mechanism gets completed. Now the next slide we will see is some basic properties of the nerve and the muscle. Properties of nerve, I think I have taken this twice in the earlier class, one as a revision class and in discussion, and other in the lecture class. I'll just go through or run through the slides here. What are the properties of nerve? Basically, the function of the nerve is that it should transmit information from one neuron to another neuron. The basic properties are excitability, conductivity, all or none law, refractory period, accommodation, summation, and indefatigability. Now, excitability means the ability of it to respond to a stimulus. What is a stimulus? Stimulus is a change in the external environment. So, any change in the external environment of the neuron there will cause as a stimulus, and that stimulus will affect the neuron and will cause certain changes. The ability of the neuron to respond to these changes in the environment or to respond to the stimulus is called as excitability. So on what factors does the excitability depends? Excitability depends upon the strength of the stimulus, that is if the change in the environment is very strong, how strong is it present, how frequently it is present, and how much time it is present. Now you have got the strength duration curve where you have got Chronaxi and inverse ratio, this we will leave. So excitability is basically depending upon certain neurons, like for example calcium ions. A good normal calcium ions causes normal excitability. Local anesthesia like xylocaine or procaine will inhibit the excitability. The clinical usage here is when you give certain regional anesthesia or local anesthesia, that is spinal anesthesia into the spinal column, or when you give a local anesthesia, you are injecting a drug which is called as xylocaine or procaine or lidocaine. When this drug is injected, it blocks the conduction of the nerve. That means, suppose you want to give anesthesia, you want to do a suturing at the injured site, you just infiltrate that particular area with a local xylocaine. You will find that the patient will not complain of pain, or he will have loss of all the senses. Similarly, anesthetist, when he injects a drug into the spinal cord, into the spinal canal, he is injecting some amount of local anesthetic. This anesthesia will block the transmission of impulses coming out from the spinal cord. So when he gives that at the L4, L5 level, L1, L2 level, when he injects the drug, after the drug has been injected, all the sensations which are coming out from the spinal nerves gets blocked. So they are anesthetized, so there is no sensation felt, and then the surgeon can operate. So what is the mechanism of action of the drug? The mechanism of action of the drug is it decreases the entry of sodium ions into the neurons. Once the drug is infiltrated, sodium ions cannot enter into the neurons. When they cannot enter into the neurons, depolarization doesn't take place, action potential doesn't take place. So there is no transmission of impulses taking place. This is a reversible phenomena. The duration of that anesthesia may depend upon the drug, maybe 30 minutes to 40 minutes to 50 minutes. After that, the excitability returns. So in other words, what is the local anesthetist doing? The local anesthesia doing, the drug is reducing the excitability and conductivity. Action potential, just remember one thing here, it has got three things. There is a resting potential, then there is a threshold potential, there is a firing potential, then three waves are present. You have got a depolarization, repolarization, and hyperpolarization. Here I will just go through. This is the resting membrane potential. A small stimulus given causes opening up of certain channels. It causes entry of sodium ions. The potential slowly rises from minus 70 to minus 55. This is the generator potential or the receptor potential. Once the generator potential reaches the critical potential or the threshold potential at minus 55, hundreds of sodium ions will open up. Hundreds of sodium channels will open up. That will cause sudden flux of sodium ions inside, and the potential rises from minus 55 to plus 35, and that is called as a depolarization phase. At plus 35, two things are happening here. At plus 35, the sodium channels close and the potassium channels begin to open. When the potassium channels begin to open, there is potassium which is moving from inside to outside. So when it moves from inside to outside, it carries positive charges from inside to outside. Loss of positive charges inside the nerve will make it little negative. So the potential falls back and it falls back below the resting membrane potential. So this falling back of potential from plus 35 to minus 55 is known as, or 70 is known as repolarization phase. Falling below minus 70 for few seconds is known as hyperpolarization. At this point, at 6 point, what happens? The potassium channels close and the resting membrane potential is maintained. So because there is a loss of potassium ions here, to restore the loss of sodium ions and potassium ions, we know that during an action potential, what has happened? Sodium has gone out and sodium has come in and potassium has gone out. To restore this balance, the sodium potassium comes into picture, and this sodium potassium pump is an active pump and it restores the concentration of the ions back to normal. The potential is maintained at minus 70, which is the resting membrane potential, till the next stimulus happens. Whenever the nerve is stimulated, the same things will happen. So this is about the action potential. Then there is another period which you should know, that the refractory period. Refractory period is the period where the nerve cannot fire again. So this period of unresponsiveness is known as the refractory period. There are two refractory periods, absolute refractory period and a relative refractory period. In absolute refractory period, any strong stimulus given also will not generate a response because the sodium channels are still inactivated. Whereas in a relative refractory period, some sodium channels are still open. A strong action potential can cause depolarization. Hence, in relative refractory period, the nerve or the muscle will respond to a little stronger strength of stimulus. Accommodation. The accommodation means a slowly rising membrane. If the membrane is depolarized slowly, it will never get degraded. It is known as accommodation. That means, in simple words, a slowly rising stimulus will not generate a response, and that is known as accommodation. All or none law, it follows the all or none principle is followed here, and whether a nerve responds, it responds completely or doesn't respond either, it is known as all or none law. Then there is a saltatory conduction. Saltatory conduction means that jumping conduction, it is because of the myelination there. Thank you. And with this we complete our revision program, and with this class we complete the whole theory and the revision classes which I have taken. So we stop the physiology classes from here. From henceforth you will not have any physiology classes till you come back and conduct the practicals. Thank you.